Our next presenter is Dr. Raquel Zita Gomes, who I lovingly call the Lady in Red. She's a dental medical doctor by the Faculty of Dental Medicine of the University of Oporto. She's a postgraduate in implantology from the Brandmark Institute and the maxillofacial surgery ward in Sweden in 2002. She has a PhD degree in oral surgery and implantology.
I'd like some
Faculty
water,
of
if
Dental Medicine
possible.
of the University of Oporto. She's a certified oral surgeon, specialist in oral surgery by the Portuguese Dental Medical Association from 2017. She has given many lectures, courses, and workshops all around the world. She has published articles in national and international magazines, newspapers, and books. She's a mentor of the professional group on Facebook called Follow the Red with over 15,000 followers, and she is the international leader of the Divas in Dentistry project. Ladies and gentlemen, I'd like to present to you my friend, Dr. Raquel Zita Gomes.
Good morning, everyone. First of all, thanks to IADEC Dubai. It's my second time here. I was here last year. And thanks to all the Ritter team for the invitation to be here. My topic today will be the guidelines for loading protocols in implantology. Where I'm from, if you don't know already from these images, that we have beautiful beaches, castles, bridges, all these monuments, palaces. If you don't know already, you will know in the next slide. I'm from a beautiful city in the north, from Oporto wine, so I think it's a good clue. And in the next slide, you will, okay, it's working now. So now we will know where I'm from. I'm from the country of Cristiano Ronaldo. For me, the best player in the world, but of course, and I'm very proud to be Portuguese. And who I am. First of all, I'm a woman, I'm a mother, I'm an entrepreneur, and basically, I'm a woman in a man's world. Since in oral surgery, mainly we have men, and also on stages. This is a little video showing a little bit my titles and who I am, because more than being a speaker, of course, I'm a real person. I'm a mother, wife, an instructor, entrepreneur. So some confidential information, okay? So for now, I have a 12-year-old daughter. I remarried again. I have a second husband that helps me a lot in the clinic. He's not a dentist, thanks God. Now the counting is going up, so more than 35 countries already, including Dubai. That was one of an extra country that I add to my list. And this is not the next stop to lecture, it was the last one, but I think it's very important because some of my friends are here. It was in Las Vegas at Dental XP that I had the pleasure to be there also speaking. This is some of my contacts that I will share at the end too. So this is only to show that, of course, I have contacts, I have connections with universities, with platforms, with dental platforms, with and I'm a reviewer. So I have, of course, collaborations with a lot of institutions. So where should we start? Of course, going back to the basics. And we know that implant stability is key to the success of the implants. And we know that we have a primary stability that is a mechanical stability, and the secondary stability that is a biological stability. But when we consider the full stability, we have a break of stability around 3-4 weeks. So that's why we should do immediate clothing, or you should wait a little bit longer. And we have like what we call subjective ways of seeing the primary stability, the percussion, the sound. The X-ray is sometimes also very subjective because it looks very good and sometimes the implant is not integrated. And the objective ways of seeing the stability, that we know the torque, the ISQ, that means implant stability quotient. Okay. So the torque measures the rotation stability, but only gives me one measure one time. So it's a limited information. What about the ISQ, implant stability quotient? So it measures the vibrational stability, the actual stability, and it can be measured several times during the long term of the implant. Even after 10 years, if I have a screw retain or a prosthesis, if I remove the prosthesis, I can measure the ISQ and compare to the initial status. And what is ISQ? Basically, it's a scale of resonance frequency analysis, and it ranges normally from 55 to 85 in a healed implant. And if it drops quickly, it's a way of thinking that we have a problem and we should go one step back. I'm going to show the cases. And how should we measure? With an apparatus of resonance frequency analysis that has a vibration and it gives you a number. And then it's very important that we have a tip that is called SmartPack that is specific for each brand of implant, each connection of implant, not brand, but the connection. And then you have to screw it between 8 to 10 Newton centimeter. Otherwise, the measure will not be correct. Of course, with your hand, normally you can do this. If not, if you're not sure, if you're doing research, use a specific instrument that calibrates the torque to screw the SmartPack. And the normal behavior of the ISQ, as I was saying, we have like normally primary stability and then a decrease of stability around 3 to 4 weeks. So the worst case scenario to touch the implant again is between 3 to 4 weeks, and then it raises again. So as I said, or you do immediate loading if you have the conditions, or you have to wait a little bit longer. Normally, at least 6 to 8 weeks. And we were curious about this, and we did some research at the University of Porto, and we studied the worst case scenario, the posterior maxilla, and we considered even the worst case scenario in the worst case scenario. So 3 different levels of bone regeneration: non-regenerated, partially regenerated, and sinus lift and filling prior to the implant placement. And what we found was quite interesting compared to what it was described in the literature, that we didn't have any breakdown of the ISQ. It was quite stable. And we thought, why should this happen? And we know that probably it has to be with the macrostructure, the macro design of this specific implant, that is the knife thread, and also because of the microstructure, so the surface. And how to measure the implant stability quotient in the secondary stability? The only way is the ISQ, because the torque I can't measure again. The only way I can measure again the torque is to do the reverse torque, and I have to remove the implant out, and no one wants that. We can do this in research, in rabbits, in whatever, but not in persons. And what about the bone density classifications? We know that this old way of seeing the bone density classification is very useful, but it's very subjective. What does it do for me and for other people? Sometimes it's different because it's a sensation, it's something very subjective. So nowadays, we consider a different way of seeing the bone density. We call it the new school, okay? And we can do it in the TC, in-house field unit. It's very easy. It's a tool that normally comes with the with the programs, and we can classify the bone density in house fields unit between D1 and D5 from MISH classification. But what about the CBCT? Because nowadays we know that mostly we don't do TCs anymore, we do CBCTs. It was not proven that the house fields units were connected or at least correlated with the torque and the ISQ. But because we are very curious in our faculty, we did a study and we compared that. So we saw the CBCT, the bone density house fields unit, we measured the torque, we measured the ISQ, and we did a regression, the linear regression, and we find a positive correlation in 74% of the cases. So maybe we can use the CBCT also to predict the house fields units and bone density and primary stability with in a good way. This was already published, but we are also working in other publications about this subject. And the loading protocols, what is immediate? Immediate doesn't mean it's in the day or in the hour. It means it can be till 3 days after the surgery. So after 48 or 72 hours after the surgery, is still considered an immediate loading. And then the early loading till 12 weeks, and then the delayed loading. And why do we need this? This is very important to have guidelines. We have more than 1,000 articles that make these rules. It's not my articles, it's not other article from other research or clinician, is 1,000 people that contributed to this scale. So basically, we have to think of this of a traffic light. So if we rather have a red color in the stability, that means lower than 60, we have low stability, so we should put a cover screw. If you have a medium stability, the yellow, we can put the healing abutment. If you have a green stability, that means more than 70 in general terms, we can do immediate loading. Of course, there's some little differences, and I'm going to explain why. Because it depends if it's a single implant or multiple implants. Like the ballerina, as you can see, the ballerina is not like blocked, so she can do all the movements, including the rotational movement. So these are the protocols with high success to choose between a surgical protocol. So if I have torque less than 30 and ISQ less than 60, I should put a cover screw. To put a healing abutment, I should have ideally more than 30, ISQ between 60 and 70, and ideally, in a single tooth restoration, we should have torque more than 45 and ISQ more than 72 to do immediate loading. What about the multiple? The multiple, of course, if we splint the things, the values are a little bit downgrading, and it's normal that the values are a little bit less, so we consider instead of 30, the threshold 25, and instead of 45, 40. And when we think about immediate loading, we can consider 70 in the all implants and not 72. But there's more things to consider. As we know, medicine is not mathematics. So, of course, we have like very objective ways to measure the ISQ, the torque, the bone density, but after that, we have to see the complexity of the case and the medical status and habits of the patient, because sometimes you have to think about the patient first and be ethical and see, okay, maybe I will risk too much if I go by the guidelines. So your clinical decision is always more important than any guideline. And I'm going to show that with some cases. So the show must go on. Let's start to apply these concepts and show some clinical cases. Some have more long-term follow-up. The other ones are more new. But to show a little bit my way of thinking and how I apply these concepts that I showed that are in the literature. So this case, this patient has a big atrophy bilaterally. He has pathology in these molars, these first molars. He has epilepsy. He uses a traditional removal of prosthesis. And because to do something like predictable at long term, I need to do bilateral sinus lifts, I thought to maintain temporary these teeth that are hopeless, just to maintain the temporary prosthesis, and then just extracting this tooth after the healing of the sinus lift that is between 6 to 8 months. So this is not very typical, okay, and I'm going to explain, and I'm going to show that one side went perfect, the other side we had some complications, but this is life, okay? This is what happens when you work and you do a lot of cases and a lot of referrals of difficult cases. And we have this bone density. Of course, we expect to have like no very good primary stability at the beginning. And we are doing bilateral sinus lift. As I mentioned, these tooth are hopeless, the 6, but I'm doing the sinus up to allow the patient to maintain the temporary prosthesis as it is, okay? And so the protocol in both sides were the same. We opened the window. We confirmed that we didn't have any fenestration of cyanide membrane. Of course, we have to go up. We used some collagen plug just to be sure, okay, just a prevention. We didn't have any fenestration. Some xenograft with collagenated xenograft. I prefer bovine I prefer porcine than bovine, but almost anything works in the sinus because it's a closed cavity with potential of healing. And in the other side, we did exactly the same. I'm not going to show, we don't have time. After 6 months of the healed sinus, it looked good. The patient didn't have any complaint. So we decided to go for the surgery of the 6 straight implants, extracting this tooth. And we knew from the beginning that the crest was really, really thin on the anterior zone. It was kind of knife shape, as you can see. And of course, after cleaning everything, it was kind of a mess. But we told the patient we are going for an hybrid situation to compensate with metalloacrylic prosthesis, and we didn't want to do more grafts on the front, only grafts. So we decided to go with a little bit different approach. We had this pathology on the left side, so it didn't integrate. It looked good in the X-ray. So as I said, the X-ray, it is what it is, but it's not always a true information. We have to clean everything, and we had a black hole, basically. So in this case, I used some low-level laser therapy as antimicrobial photodynamic therapy. That means we put a blue dye, methyltoluene blue, that stains the bacteria, and then we use a red laser, a diode laser, 660 nanometers, to kill the bacteria with an oxyreduction reaction. Just to explain what is this blue dye. And this is called antimicrobial photodynamic therapy. So we clean everything. I do this for protocol for post-extractional, and whenever I have pathology, the implants were placed, but in a way that were what we call in anterior zone the palatal approach, okay? Because otherwise, if I go with the burr in the first ridge, it goes away. As you see, the torque was not very high as expected because the bone was not very good, and the density was also not very good, so it was expected. We published also about this technique of palatal approach at Edit Journal in 2020, and is a technique that I'm performing for more than 20 years. We have very good results because in palatal we have a thick biotype, so normally we don't have any retraction, and is a cortical bone. But following, as you see, the anterior are in palatal approach. The other ones are basically on the septums. And my decision was, even though I had this problem with the left side of the sinus, I still managed to put the implants on the septum. These are the ISQs, not very bad for this situation, but of course, in this situation, low stability means red means cover screws, okay? And wait. So put the cover screws and wait for biology. So that the mechanical stability will be then a biological stability. You use some pulmonary fibrin together with autologous bone to solve the problem, but initially we need to solve the lack of stability of the membrane, because as you can see, the membrane was completely ruptured. I have to clean everything and to disinfect everything with the laser. So my idea was, because the membrane was very thick, to suture the membrane to the wall, okay? This wall was so thin that with a non-resorbable suture, I could manage to penetrate the wall. But sometimes, if that is not possible, you can use a small burr to perforate the bone and then use of course, a resorbable suture, because it's going to stay inside, just to stabilize the membrane. So after stabilizing the membrane, of course, you can use all this new technology of plasma-rich fibrin that has growth factors, that helps healing, that protects the membrane, collagen membrane, xenograft, the traditional way of doing things. But we are doing kind of in a reverse way. I did it first. On the other side, it was perfect, the healing. And on this side, we had this complication, so we need to solve the complication. Of course, most of the times we don't have complications, but I think it's more important to show the complication and how to deal with them than show all the perfect cases. And then, even in this case, I grafted a little bit palatal because I have one or two spira that were exposed, but even if I don't put anything, it will be good stability and good prognostic to long-term survival. Then with some membranes, the traditional protocol, and we are closing everything and waiting, of course, after 15 days, after 1 month, after 6 months. In the day of the surgery, we just did a soft reliner. We extracted tooth. We augmented the two teeth that we extracted in the lab, and we maintained this 7 just to maintain a little bit retention of the temporary prosthesis and to give us the vertical dimension and the proprioception to the patient. And after a few months, my team did the rehabilitation with metal acrylic retained prosthesis, and this case has more than 7 years follow-up. And we talked about a difficult case in the maxilla or an atrophic case in maxilla. Let's go to the lower mandible. And we know that sometimes the atrophy is so big, normally in cases that they already lost implants, that sometimes we need to deal with the inferior alveolar nerve. And this nerve, as we know, is a sensitive nerve. And there's some ways to mobilize the nerve when it's not possible to avoid it. And basically, we have the transposition and the lateralization. I'm going to show one of each case to show how does it work. So basically, the indication of this technique, we have to have at least total posterior height from up to bottom, at least 8 millimeters of the mandible height, because if we do a window like a sign was in the lower kind of, if you don't have at least 8 to total height, the risk of fracturing the mandible is high, okay? And less than 9 to the top of canal. Of course, if I have 9, I don't do this kind of techniques. I use like short implants or tilted implants, whatever. So I only use it when I have like less than 5 or nothing, or 3 millimeters or nothing, because technically we have to have 2 millimeters of safe to the canal. So basically the difference between a nerve lateralization and a nerve transposition is in the lateralization, we pull all the complex of the nerves out And we shouldn't push more than 5 millimeters because the nerve doesn't like to be pushed too much, otherwise it also gets paresthesia. But we push and push back. So in the transposition is slightly different technique. We go medially and we cut the incisive part of the nerve, not the mental part of the nerve, not the inferior part of the nerve, but the incisive part of the nerve, okay? The one that goes to the front that has connection to the other side, 3 millimeters in front. So these are the difference between both of the techniques. And ideally, we should do piezo surgery, of course, because it cuts hard tissue, it doesn't cut soft tissue, but sometimes we need to improvise. And I'm going to show a case that I had to improvise in a patient that also is my cousin. And I have a specific protocol to revert the temporary paresthesia that always happen. I always use corticotherapy, plasma-rich fiber and vitamin B complex, ideally for 2 months, 1, 6, and 12, and then low-level laser therapy as a biostimulation. Okay. So this case was the case that is not the pattern case, okay? It's a lateralization. I didn't use the piezo, but this is what ideally not to do, okay? But the piezo broke, so during the surgery, the patient came from outside, and I was like, okay, I need to solve this. So I have experience with these techniques for at least 10 years. I'm working for a surgeon as 20 years, so I risk it to do with a burr, but it's not what is traditional, and next I will show what is supposed to be done, okay? And this tooth was hopeless, and the bone density was between D2 and D3. She already had lost implants. Almost all these cases are lost implants before. And as you can see, we initially visualize the nerve. We retract a little bit the nerve. This is pencil. I use a pencil, traditional pencil for school. We put it in the autoclave, we sterilize, and we draw what we need to do. And after extraction the 45 teeth, I go anterior to do the incisive part. In this case, I did it with a burr. I'm not going to lie. As you can see, distally also I did it with a burr. And then I use a chisel just to break between the medulla and the cortical. I remove all the cortical that normally I reuse again but this is not the traditional way of doing, okay? I do a lot of these procedures, and it was my first time using a burr to do it because my piezo broke, literally. We are using the top part of the gloves, of some part of the gloves, the sterile gloves, to do the retraction of the nerve, not being too hard. We can use like strings from periocardial, vascular surgery or whatever, but this is very cheap because you cut just the part of the glove and it's sterile. As you can see here, we are now retracting all the complex. Of course, you have to have a very trained team to do this. Normally I work, me as a first surgeon, a second surgeon to assist, and a well-trained assistant helping in the surgery, and one circulating, and the photographer, so it's a lot of people. So we are preparing for the implants. We have to be careful to retract the complex. In this case, we managed to have this torque 30 and 35, and ISQ 68 and 70. Technically, with these values, I could put helix. But because I had an extraction, the patient has periodontal problem, it has beginning of diabetes, I didn't want to risk. So my clinical decision was, let's cover and wait, okay? So this is an undergrade of my guidelines, okay? As you can see here, the implants, I put it normally with bicortical anchorage. Sorry, my pointer is not working too well. Okay, as you can see, they are going to cross between the cortical and upper and lower. We are not cutting anything, just retracting, and using some PRF just to recover the nerve of the fascia to stimulate the healing. This is a sensitive nerve, not a motor nerve, as everyone knows. So it takes a while, normally about 2 months to recover totally the paresthesia. So it's only a sensation of a lack of sensation, not any motor component. After suturing, after healing, this is the X-ray after the surgery. This is still an ongoing case, but just to show that sometimes it's better to go a little bit down and not risk too much and put the healing abutments a few months later. So I didn't risk to put the healing abutments even if I had the conditions to do so. So then after 6 months, ISQs of 75 and 77, okay, now we can wait a little bit to mature the gum. Sometimes we need to do some grafts of the soft tissue because on the posterior mandible we have very bad soft tissue keratinized, and it's an ongoing case. And now I'm going to show how to do it in a more proper way. It was a referred case. This patient was already lost this distal implant and was losing the implant on the 44 position. It was referred by a colleague that is a prosthodontics from Italy. He came with a patient to Portugal, and the Hounsfield unit were quite good because it was quite cortical, the bone, D2 in the posterior region. And this is a small video because I think it's a little bit easier to show the procedure in a video. And this is a transposition, so a little bit slightly different from the other one that I showed. That was a nerve lateralization. We are taking the blood. In Portugal, it's allowed for the doctor to take the blood. In some countries, it has to be a nurse or whatever. But we are opening with a full thickness flap. As you see, the old implant is with some lack of bone. It's an old implant with more than 22 years. It was a Brandmark MK4, something like that. So we use a retriever to remove it, as you can see. And also because the position of the implant was not quite perfect, so we prefer to do a new implant in a more correct position. We are using the low-level laser therapy with 660 nanometer, and this is the proper way to do the surgery with piezo surgery, different tips, saws, and here we are doing the transposition, so that's why we're cutting 3 millimeters in front of the mental nerve. So we are cutting the incisive part of the nerve to have a mobilization to distally, okay? And now, in this case, I managed to maintain part of the block of the mental foramina. Not always is possible. Normally, I don't maintain, but in this case, it was manageable to maintain the part of the mental foramina, and I just slightly distally, and I maintained, okay? But not always possible. Of course, the bone that I'm removing, then I can use a bone meal, I can use several ways. It's very difficult to put it back again. It's possible. I have cases that I managed to put it back after slicing, but normally you need some retention and it's not so easy. So normally I just use a bone meal and transform a block in a more paste bone, like triturated bone, and I put it back because it's autologous. So showing how I'm adapting the mental foramina distally, and we managed to block it. And then we're going to put the implants bicortically. Normally we go really to the basis of the mandible, preparing the trepanation for the implants. You can see the nerve. Of course, the person that is helping you in the surgery, because I'm preparing the implants, has to be very careful retracting the nerve for me not to damage the nerve while I'm preparing you the burrs. And be careful with the type of burrs also that you use, because some implant systems have like burrs that are very aggressive, like Linderman. So be careful with this kind of burrs on these procedures. Prefer like more traditional burrs, not very sharp. We are preparing, trying to be most parallel as possible. In this case, we are putting 3 implants, one in the one that we removed, and the other ones to distally. Of course, we can't go too further back because the nerve is crossing lingually, so it's more difficult to remove it back. So as I can see, this is a transposition, not a lateralization. We are putting the implants. You can see here where the nerve was cutted. And now we are doing the procedure like I did in the lateralization. We are putting some PRF around the nerve to help the Schwann cells to gain some new conductivity and to help healing the paresthesia faster. But the protocol, this is the autologous bone that I used in a bone meal to put whatever we needed to. And then we are going to close it. Some PRF on top also because helps with soft tissue. Then we do the first session of the laser intraoperatory, and then normally from 3 in 3 days. The protocol is between 6 to 10 sessions with red and infrared laser. The red is more for anti-inflammatory purposes, and the infrared is for more biostimulation of the conductivity of the nerve and also for the healing. This is immediately after the surgery. Then the soft tissue was not perfect, so we decided to do some grafts, some free gingival grafts, and we improved a lot the keratinized tissue. And this was the final ceramic bridge done by Dr. Pierluigi, that is the prosthodontics from Italy. This is the protocol of the paresthesia. So infrared 780, red 660 with these sets that are already in the apparatus, okay? And we do it between 6 to 10 sessions. This was the paresthesia after 2 days of surgery, okay? It could be a whole of this square of the face, but it was kind of small for the type of surgery. And this is the patient. I did the surgery in Friday, and it was on Monday, so 3 days after. And we did another laser therapy. And we are quite interested in the follow-up of these cases. And after 2 years, we did a CBCT to control, and we can see the new foramina distally and repositioned. So you can see that the implants are completely integrated. Then, of course, with time, the bone heals, but you can see the new foramina distally. And then this is a more straightforward case, not so very straightforward because he also needed some grafts. Statics is always difficult, and the bone was D2, but it was quite atrophic, as you can see. So in this case, we shouldn't put the implant directly. You need to do some procedures before. And at that time, this patient had to have removed the wisdom tooth. That was not very easy. It was one with a hook. And also, we used this time of surgery to remove a block from the rectoromandibular area to put it on the front part. This patient is 27 and he's a dentist. So imagine. So not a very good patient. So after removing everything, we put some PRF, some plugs of collagen, we suture, and then we prepared the block to the anterior zone because it was quite atrophic. We used the osteosynthesis screw, and we waited for a few months. Also, we used the dentin graft because we were removing the wisdom tooth. Why not using the wisdom tooth that was inside, was with no caries, to do some dentin graft as a bone biomaterial. It's very cheap because it's autologous, and this is what you see is dentin after dentin grinding and dentin graft. Of course, with some PRF, with some membranes, we have to wait, some sutures at the beginning because we only put like a teeth to the distal teeth with some composite, kind of a Maryland, not a Maryland, just a prosthesis teeth. And then after 6 months, we reopen. It was quite better, the quantity of bone, not perfect, but quite better. We avoid touching the papillas because we don't want to lose the papillas. The patient has a low smile, but anyway. And after removing the screw, the osteo, you can see the difference between before and after. So it was quite atrophic, and after, this bone is very cortical, so it's very stable. Of course, to put the implant, you should put in native bone and more palatal, like any other anterior case. So more palatal. Try to avoid touching this bone that was kind of grafted, because there's some risk if you go like with a lot of force, with a lot of torque to detach it. It's not so easy, but it can happen. And the torque was 45 and the IST 78, so we had the right conditions to do immediate loading. But in this case, this is a son of a lab technician. So at the day, we only put the tooth like on the lateral, and we did the impression, and it went to the lab for the father to do the provisional. As you can see here, we use some soft, autogenous bone from the burrs just to put on the place that I removed the screw, okay, and some collagen plugs. And the healing abutment, we did impression. This was the X-ray immediately after placing. And then this after suturing the day, and after 3 days was already like this, so very good healing. And we did the provisional. Initially, we thought about doing it with traditional metal temporary, but then we realized that we could do it with this plastic that is kind of a scanner, and it can be used as a temporary abutment also. And is very flexible, so it's a good way to do the provisional. So we did it with this specific. You can see here the CBCT after the surgery, and the provisional in place is still a provisional, okay? It's an ongoing case, but just to show that sometimes you need to do the conditions before and create the conditions before, and then you have the right conditions to do immediate loading. And in this case, it's still in healing process. And you can see here the position on the CBCT and the cortical of the bone, very, very hard of the block that we did a few months ago. And the dentin grinding. Just to finish, as a conclusion, we know nowadays we have all the technologies, all the techniques, all the integration softwares, digitalization. We can practice implantology in a more faster, efficient, and safer way. Of course, we need to have the technical knowledge first, but we are, with our life, facilitated. I think more important is to have some simple take-home messages, and I'm going just to show one slide. We should use like objective measures to take the right clinical decisions, and the objective measures that I presented here and should be considered is the ISQ implant stability constant, CVCT in a way of bone density, and the torque. And we know that torque we can only measure once. The ISQ is the only way to, follow up the implant at long term and measure the axial stability. That is a different measure from the torque that is rotational. And the bone density can be assessed before today in the TC and in the CVCT, and we proved that we have some correlation. And this is the rules, okay, for a single implant, ideally, okay, this is the ideal situation. Torque more than 45, ISQ more than 72, do immediate loading, no problem. And multiple implants, torque more than 40, and ISQ more than 70. Of course, these more demanding cases like the nerve lateralization, nerve transposition, sinus lift and filling graft, complications, have specific indications, and you have to know and be prepared to deal with the complications. If you're not prepared to deal with the complications, it's preferred to refer the case. And as a general message, sometimes if you are very good in doing something, but you don't leave your comfort zone, you'll be very good, but you will not be great. So sometimes you need to leave your comfort zone and try that the magic happens, and sometimes go crazy and go jumping off the planes like me, that I'm afraid of heights. And sometimes you need to push a little bit your boundaries with some notion. These are my contacts on LinkedIn, on Instagram, my personal email, my Facebook group on Facebook, follow Red. I will be here during the day and during these days. If someone has questions or wants to contact me by email, I will be happy to try to answer. Thank you.
As usual, it is a pleasure to see you again. It's a pleasure to listen to you. And as
Thank you.
appreciation, we have the certificate.
Okay, thank you.